Thank you for joining. So I will start with a case, then we'll move ahead with the flow. So a 65-year gentleman diagnosed with having severe back pain. Patient was diagnosed to have adenocarcinoma prostate with multiple bone metastasis, Gleason score of 4+4. PSA was reported as more than 100 nanogram ml for outside. So now how to proceed? Please.
Currently, the metastatic disease, symptomatic and PSA is more than 100, high risk patient. So prefer to add ADT with chemotherapy. Start with ADT with chemotherapy.
Okay. Anything else anybody would like to add? Yes, definitely. ADT, early starting of ADT will be important. And yes, starting of other form of treatments will be important. So, counsel our patient that there are two forms of treatment we have to do. That means castration can be medical or surgical. At the same time, we have to give either docetaxel or abiraterone plus docetaxel or enzalutamide. These are the various options available. So how to select among the other options? So ADT, we all are here and you counsel for surgical versus medical castration. That is too much discussed. I do not discuss that. Now we have option of dosi versus abira, dosi plus abira or enzalutamide. Now how to go ahead? Let's take a minute.
Based on patient preference, patient comorbidities, I think I would proceed. Many of the times, what I've seen or experienced in prostate cancer patient, many patients are not very much willing for chemotherapy per se. So if that's their choice, we'll go for ADT plus abiraterone or.
No. So that is very fair. So we need to consider about the comorbidities. We need to consider about the patient preference and definitely disease burden as previously highlighted. Higher disease burden, we tend to prefer towards chemotherapy. Important point from my side here is that we need to counsel our patient that if patient is choosing oral treatment now, the patient might be having somewhat poorer performance status down the line, also more age. So around 2 years, for example, if patient is around 80 years, patient becomes 82 years, now it will even more difficult to give docetaxel to that patient. That is why if patient is a higher disease burden, we tend to strongly counsel better to take chemotherapy now. It can be other formats. For example, in some patients who doesn't look very fit, we can consider docetaxel 2-weekly protocol, which tends to be somewhat better. Any comments, sir?
Actually, since this patient is a treatment naive, upfront patient started on ADT, and we expect that this is going to be a castration sensitive tumor with high risk features. So we'll first I would like to first counsel with a combination of ADT with abiraterone, and ask for the patient about the preference and the affordability factor. If patient is affordable and good PS patient, then I will prefer the combination. And depending upon the selection of duration of docetaxel, I have experienced maximum with a three weekly docetaxel rather than 2 weekly docetaxel. So I will go ahead with my experience.
Okay. Sandeep sir, in this scenario, now we have also an option of utilizing enzalutamide. In which selected groups of patient utilize enzalutamide upfront, because the usual training is that we tend to utilize abiraterone more of upfront, though there is clear-cut data to utilize either of the two upfront.
Yes.
But we tend to utilize enzalutamide somewhat later in the line. What is your comment on that?
So my choice between abiraterone and enzalutamide, I choose according to patient comorbidity status. And I keep the fact in mind that when I'm choosing enzalutamide, abiraterone in future may not be that much of efficacious. And in this patient, definitely I will want to use the docetaxel first, because my patient may not be having a fit performance status later on.
No. Dr. Preeti, if patient specifically wants to ask why can he be taken for enzalutamide, in which selected group again you'd like to prefer utilizing enzalutamide over abiraterone? Any selected group of the patient?
I'm not aware whether
because the problem is that yes, please go ahead.
If there is a contraindication to use steroid along with the treatment, because docetaxel and abiraterone both require steroid with them. So if I want to avoid the steroid, then in those patients I will like to.
Yes. Apart from that, yes.
Yeah, I think if cardiac comorbidity is there, already patient is having CAD, that time also
Yes.
I would like to prefer
Completely agree. Completely. Ejection fraction 45%. In data for safety is more with enzalutamide. That is why another point, because abiraterone causes some amount of fluid retention, while enzalutamide doesn't cause so much the same. That is why we tend to provide enzalutamide in such patients who are borderline and point well highlighted. So these are the scenarios they are based on. So there is no single answer, but depending on the various prospects, various suspects, we need to select.
High risk, but not much symptomatic. So enza and abiraterone can be used upfrontly. But if the patient is so much symptomatic for bony pains or any visceral mats, so preference is docetaxel. I'm using 2 weekly schedules more preferably nowadays since 1 or 2 years, because patients tolerate very well. Doses is 50 milligram per meter square. So I think 3 weekly is the dosing is incomplete. Suppose the dose comes to 150 milligrams, so we can't give the full dose. 120 is maximum, 120, 130. So I think 2 weekly schedule is proper. Patients come regularly, and I think patient tolerated very well, and response is so dramatic. And in some patients, if the elderly patient 70 or 72, so weekly docetaxels can be used in spite of two weekly docetaxels. So in some patients, we can use the weekly docetaxel also.
Okay. So I completely agree. 2 weekly docetaxel, we have also quite a bit significant experience. The only problem with utilizing 2 weekly dosi, instead of every 3 week steroids, you will have to give 2 weekly steroids, because the pre-steroid dose and afterwards dose, it remains the same. Here comes the role of Aqualip preparation. That is.
So I think we are docetaxel still there is with conventional or with the Aqualip. So I think we are not using steroids apparently nowadays in Aqualip. So if we are using the docetaxel, the chances of hypersensitivity reaction is very less compared to the paclitaxel in conventional form. So 8 milligram, 12 milligram is sufficient, but I think with Pacli Aqualip we can avoid the steroids also.
Dr. Preeti, with this Aqualip preparation, whether you would like to give those steroid or avoid?
No, not required.
Not needed. So that is the benefit of using this preparation. It becomes very easy. So wherever we are utilizing 2 weekly protocols, if there is a clear contraindication to use the steroid.
One point is in my mind, suppose we are discontinuing the steroids, but the docetaxel plus prednisolone is part of this protocol. So we are giving this oral medications, prednisolone 5 milligram daily. So the steroid is giving in daily doses. So I think on part of this, the day of the docetaxel was not using, but we are using the on other days also.
But that is for CRPC only, not for HSPC. So in HSPC setting, Dr. No, what do you think? Yeah.
Yeah, I agree. I use in CRPC setting.
Yeah, in CRPC, the recommendation is to utilize prednisolone daily, apart from DEXA. But in HSPC, there is no specific indication. Completely agree. So here we have discussed about the important points related to utilization of various amount of these treatments. We have actually 4 studies in HSPC setting ongoing. One study is we tend to see P10 alteration at the baseline. If P10 alteration is detected on the IHC, the patient goes for the capivasertib study, where abiraterone is combined with capivasertib. So that is an option. If trial is available at your center or at your nearby center, there is an option to utilize the same. At the same time, we are having a randomized trial where the PEACE-1 protocol, that is docetaxel plus abiraterone, will be compared with docetaxel with abiraterone low dose, 250 milligram dose. At the same time, we are having third trial as well, where docetaxel 75 milligram is being compared to docetaxel 60 milligram per meter square at this, and also pharmacokinetic comparisons. The justification for this third one is that we tend to see that our patients are somewhat poorer tolerance to 75 milligram per meter square, but 60 milligram per meter square is very well tolerated. In Japan, there is a randomized trial which has already established that 60 milligram per meter square is functioning as well as 75 milligram per meter square. And we are trying to do a similar study in our setting to see whether 60 milligram per meter square will do as well. Sir, your comments, Jasuja, sir.
So I'm totally agree with you, Dr. Akhil. We actually important point is the toxicity, and if we can reduce the toxicity by this going what even Kumar Prabhas did is like low dose immunotherapy, and we can reduce the dose and with same efficacy or some kind of in metastatic setting toxicity more important point. And if either little bit compromise on efficacy, if we can reduce the toxicity, then we should do this kind of trial and we should do this kind of working in our institutes individual. This is still now it's individual, but we must try these things.
Yes, completely agree. So we have data from gastric cancers and esophageal cancer where GO2 trial and other trials have shown whether reduced doses of chemotherapy in elderly patients is having to similar side effects with improved quality of life. We have found the same in the gastric cancers. Similarly, since the patients of prostate cancer are mostly above 60-65 years, we are trying to do the similar study in our setting as well. So now one more point which I would like to discuss is utilization of HRR testing in the routine. Dr. Anu, in which patient you would like to consider utilizing HRR testing?
I would like to do in all the patients, every patient.
So at the baseline itself in HSPC setting, or you would like to reserve for CRPC?
So till date we used to do in CRPC setting, but I feel we should get it done at baseline.
Yeah, it's always good to know the status from the baseline. I completely agree. And this is a very stable mutation. It doesn't change with time. So it's not a dynamic mutation. So we can consider doing at the baseline so that you are ready with the treatment in the next time. Also, there is now data that abiraterone combined with olaparib is benefiting the patients, but that is a phase 2 data. We have not changed the practice based on that phase 2 data, but it will be coming up in a more selected population later on that it can change the practice. So yes, there are various treatments which are going to come up, many more treatments options coming up, and we need to individualize the treatment options and decide according to same. Any questions or comments from the audience? Dr. Amit, any comments on the discussion till now?
Oh, surely. So for the first line, what we say, if there's the fit patient, now we are going with abiraterone with docetaxel, both the combination and the now becoming practice in our setting. And surely if the patient is fit enough to tolerate both drugs. Otherwise, either depending on the tempo of the disease, it is only taxel if it is a going disease. Otherwise, if not a fit patient, abiraterone.
Okay. Anybody uses 250 milligram OD abiraterone in your practice, Dr. Amit?
Presently, I have not started that, but surely there are data for that we can use 250 also.
Anybody?
I have used 250 after meal in patient who are not able to afford getting the abiraterone. The cost was the issue, so I advised that he take the, rather than giving 1 gram empty stomach, give it 250 after meal. And there is a data presented in ASCO about this.
Yeah, I completely agree. We are running a randomized trial in CRPC setting for abiraterone full dose versus abiraterone 250 milligram with low fat meal. So that trial is also going at our center, and we have randomized already 100 plus patients, and the target is to go to 300 plus. So it will take some time, but we are expecting early results by 2025 end. So I think there will be another good data from India of reducing the cost of the treatment, because 250 milligram cost is reduced to 1/4. Even the cheapest brand which is available in TMH pharmacy, that costs around 7,500 rupees for a month treatment. And the cost drastically comes down to 7,500 rupees for 4 months. So that is a thing to look out, and hopefully we'll be able to answer that. So any other comments or points which you want to discuss, we can take it up, else I would like to finish off here.
The number of cycles of docetaxel in responding patients. That is
in
still a
CRPC setting?
Yes.
Dr. Anu, you would like to comment? In CRPC setting, patient is responding well to docetaxel. How much cycles you would like to continue? Patient doesn't have significant neuropathy. Till how much cycles you would like to continue?
If I'm using 2 weekly, then I'm comfortable with 9 cycles.
And we are talking about CRPC. In HSPC,
then we can continue it if patient is tolerating.
Dr. Priti?
In CRPC setting, yes, till the patient is responding, patient is not having any toxicity, continue till progression or any toxicity. And HSPC setting, 9 cycle of 2 weekly and 6 cycles of 3 weekly.
Well, so ideally, we try to continue till toxicity, but 80 to 90% patients tend to develop toxicity of neuropathy by 8 to 10 cycles. That is the usual
Giving
time.
more than 10 becomes difficult.
So after 10, it seems to be difficult, and we tend to be very, very cautious. Even grade 1 neuropathy can suddenly increase to grade 3 neuropathy, and the problem is that doesn't reverses usually. So that is the problem we take here, and it is after 10 we are very, very extremely cautious to utilize as well. Thank you.
I have a question. What is your experience with immunotherapy in these patients?
In prostate cancer. So there is a phase 2 data from the group of Neeraj Agrawal et al., where atezo has been combined with cabozantinib. We have 4 patients on that. This is a phase 2 data only, not FDA approved setting. We have PSMA therapy also available in house. Actinium-based PSMA therapy is also available at our center. So instead of utilizing immunotherapy, we tend to utilize other forms of treatment. We have a long list: PSMA therapy, then cabazitaxel, and apart from that, we have metronomic treatment also, for which we are doing a retrospective data collection. It has become more than 100 patients. It is a simple cyclophosphamide plus DEXA. DEXA 0.5 milligram in continuous doses, and cyclophosphamide 50 milligram 2 weeks on and 1 week off. That is also able to provide responses in around 50% of the patients who have exposed to at least 3 lines of therapy. Some data was published from TMC Kolkata by Joydeep Ghosh et al., but we are going to publish a data of 100 plus patients shortly. That is a retrospective. We don't have any randomized trial for the same. Thank you for highlighting that. We can consider randomized trial for that. So, thank you.
So are we doing PSMA therapy at Varanasi also?
PSMA PET is available at Varanasi. PSMA therapy is also available. PSMA therapy in the form of lutetium, PSMA therapy of actinium, both are available.
Okay. So we are doing PRRT also for.
Yes, for NAT. Thank you.
Do you get MSI testing?
MSI testing is done as a part routine practice at the CRPC. We do, but the point is that the MSI incidence is very, very low in Indian setting. For example, if we see the dostarlimab study, they have commented that 5 to 15% of rectal cancers have MSI high in their setting. But in our setup in TMS Mumbai data, we found that it is to the tune of only 1.5%. So Western data is telling that 5 to 15% MSI incidence, and that is as low as 1.5% in our own data. So we completely agree it is very low. And if that MSI comes as high, whether the patient will be able to afford immunotherapy, that is also a problem.
So how do you do MSI by
IHC? It is a very easily available test. So thank you all the panelists. Thank you judges. Thank you our audience. Thank you. Thank you.
Thank you so much, Dr. Akhil, and all the panelists for the wonderful interactive panel discussion. So I think